Welcome everybody. My name's Melanie Davies. I'm a professor of diabetes medicine at the University of Leicester in the UK, and I'm going to talk to you about the management of diabetes in people with established cardiovascular disease. So the next slide here shows my disclosures. So as a clinical academic, I do a number of studies and trials with a number of companies, and I have a particular research interest in new therapies for type 2 diabetes. So over the next half an hour or 45 minutes or so, what I'd like to do is to talk about type 2 diabetes and cardiovascular disease and the role of glucose and hyperglycemia. Talk about the approaches to glucose lowering therapy, but focus with the overview of the recent cardiovascular outcome trials and look into the future about what we can expect moving forward. And I'd be delighted to answer any questions at the end of the presentation. So I think many of us know who work in this area that we are facing a staggering increase in the number of people with diabetes, particularly with type 2 diabetes, with the numbers predicted to increase across the world globally, but particularly in parts of the world in Southeast Asia and in the Middle East and North Africa, and in South and Central America. So we're seeing huge numbers in the increase of type 2, and we're also seeing people developing type 2 diabetes at a much younger age. So we know, and this is data from the VADT, that patients only entered the veterans trial after they'd had diabetes for 10 to 11 years, and they therefore had accumulated a poor glycemic legacy with hyperglycemia, burden of hyperglycemia, and that really we should be trying to control glucose from early in the diagnosis to avoid this legacy of poor glycemic control, because we think that that is also one of the factors that's driving complications of diabetes, including macrovascular disease. However, it's not all bad news. So this is data from Ed Gregg that was published in the New England Journal of Medicine and looks at data in the US, but shows that the death rates in people with diabetes has reduced with acute myocardial infarct, with stroke. We've had less impact on end-stage renal disease, so although the numbers are gradually increasing, unfortunately the gap between those with diabetes and those without diabetes is still significantly higher. So overall death rates are reducing in terms of cardiovascular outcome, which is good news, but the gap between people with and without diabetes isn't really reducing, and we know that we're seeing complications, increasing complications in people under the age of 45 as well. So how do we modify cardiovascular risk in type 2 diabetes? Obviously we have a number of approaches, and I'm not going to speak too much around lifestyle modification or blood pressure or dyslipidemia or platelet inhibition, but these are all important factors. But I'm going to focus more on the role of glucose in terms of being a way that we might wish to modify and improve cardiovascular outcomes. So does better glucose control improve outcomes in people with diabetes? And if you look at the data, this was a meta-analysis by Kaushik Ray. It was published in The Lancet in 2009. And he looked at studies including UK PDS and Accord and VADT in advance, so over 33,000 patients. And whether you look at a particular strategy of any glucose lowering or a product-specific approach, such as Proactive with pioglitazone, you can see that there's a modest impact on outcomes, of 15% reduction in non-fatal MI, but no really convincing evidence on any other outcomes, including heart failure and cardiovascular death. If we look at more recent data, so this is Tom Udell's paper that was published in Lancet Diabetes and Endocrinology some 6 years later, so in 2015, here we're up to 95,000 patients with a number of other trials. So we now have a number of other studies, either with TZD, so Record, Adopt, or we've got other trials with DPP-4 inhibitors. And you can see that we've got more patients now, but still only modest effects. So a 5% reduction in MACE, but now we're seeing an 8% reduction in myocardial infarction, although we now start to see an increase in heart failure, probably because of the increasing number of trials which have included TZD. So if we look overall at the evidence base for the role of glycemia in driving cardiovascular outcomes, it's to this point the epidemiological data is modest. However, when we look at the developments in new therapies for type 2 diabetes, there's no doubt that we've seen much development and progression in the availability of new therapies. But also, I think we've started to understand that the patients are more complex now. So we have younger people with type 2, we have people with other comorbidities, we have an aging population, and so increasingly we're targeting our therapies to individual patients, and we're not just interested in glycemic control, we're also interested in reducing the risk of hypoglycemia, we're worried about weight, and we're considering comorbidities and also looking at whether patients take their medication. So if medication is too expensive or if it causes side effects, patients are less likely to adhere to their medication. So if we look at the metformin, which is often first-line therapy, if we look at what we add to metformin, and this is looking at A1C reductions, the data for A1C reductions in addition to metformin show actually fairly similar reductions in HbA1c. So not huge differences in the A1C reductions across these different agents, and yet this is before SGLT2 inhibitors. So many of the therapies, including SUs, DPP-4 inhibitors, GLP-1 receptor analogues, and of course insulin, are efficacious in lowering A1C when added to metformin. However, if we wish to do that without causing an increase in body weight, then we are limited. So we have the DPP-4 inhibitors and the alpha-glucosidase inhibitors, which are weight neutral, and really only the GLP-1 analogues and of course SGLT2 inhibitors now are in that role of weight losing. If we're also interested in avoiding hypoglycemia, and for some patients that's a real concern, then again we're limited in our options as we have the TZDs, DPP-4s, alpha-glucosidase inhibitors and GLP-1s and SGLT2s of course as well, which don't increase hypoglycemia when used without insulin or an SU. So I think we are in a different realm now of glucose-lowering therapies, and for many practitioners it's becoming increasingly confusing as to the plethora of new therapies that we have available across the world. So we now have the SGLT2 inhibitors, which are now in large parts of the world available. We have the GLP-1 receptor analogues, and we have the DPP-4 inhibitors, and there are within class also many choices and some differences between the ages, but within the class as well as obviously between the class. Now this is the standard of care guideline published by the American Diabetes Association, and it gives a very traditional approach, which is metformin first line, and then advocates a number of different therapies, choices for dual therapy, and then choices for triple therapy. And you could almost look at this and think that you could use every therapy for every patient, and I think that's created some confusion. I can't show you the slide, but I've just shared the ADA EASD consensus document, which will be presented in October at the EASD, and we will have a different approach in terms of the choice of glucose-lowering therapy, which will be driven more by comorbidities, particularly the presence of existing cardiovascular disease. Again, in the present guidelines, we talk about individualizing treatment and taking into account different characteristics. And again, that approach will be slightly amended in the new guidelines, and we'll really much more talk about therapies and clinical characteristics driving the algorithms, particularly at people at risk of hypoglycemia and in those in whom we want to avoid weight gain. And this is an early view of the new guideline in terms of when we talk about patient-centered care. And you can see that one of the driving factors will be key characteristics, and that will include things like the presence of either heart failure, chronic kidney disease, or particularly cardiovascular disease. And this importance of the patient at the center of care and specific factors, and the specific factors will include things like adherence to therapy, cost of therapy, and other important factors. So how have the cardiovascular outcome trials influenced the newer guidelines, and what do we know now that we didn't know a few years ago? And there's no doubt that if you look at the plethora of information that we've had just in the last 5 years, it's staggering. So we've had obviously the data from the PPAR joint agonist. We've had data from the DPP-4 inhibitors, and Carmelina has already had a press release about the results of Carmelina, and you'll be aware of the data from Examine and Saver-TIMI and TCOS. We have a series of information coming through from the GLP-1 receptor agonists, including semaglutide and liraglutide and exenatide, and we have a number of trials ongoing, including those with oral GLP-1s, as well as other agents such as dulaglutide. And then finally, we have a series of studies with the SGLT2 inhibitors. So we have tens, if not hundreds of thousands of patients either who have been in trials of cardiovascular outcome or are in studies that will report fairly soon. And obviously we've also had studies looking at insulin, particularly degludec compared to insulin glargine. So what do those studies tell us? And I want to start with the DPP-4 inhibitors. So if we look at the DPP-4 inhibitors, we've had 3 studies now with 3 different agents within the class, which in terms of the primary outcome have showed very, I think, securely safety. So these agents don't reduce outcomes of cardiovascular disease, but they don't cause cardiovascular harm. And as you know, the driving force for the original outcome studies was really to show no harm after some of the data with the TZDs. So if we look within the class, the DPP-4 inhibitors, we have 3 studies now which have not shown superiority, but have shown, I think, safety, cardiovascular safety. And we have Carmelina and also Carolina with linagliptin. And you'll have seen the press release with Carmelina, which probably moves that dot over here. But Carolina is the study compared to an SU that we've not seen yet. So the DPP-4 inhibitors are oral agents. They're fairly well established across the world now. They come from a fairly heterogeneous group of chemical structures, and they differ in some of their characteristics in terms of excretion, for example. So we know that most of them are renally excreted, apart from linagliptin, which isn't dependent on renal excretion. We know that they're fairly safe, that particularly linagliptin can be used right across the spectrum of renal impairment, but I think they're rarely well-used agents, and their main, I think, advantage is the fact that they have reasonably good A1C reductions, but as you know, compared to a sulfonylurea, no increase in hypoglycemia and are weight neutral. And this is the data from Baptiste-Gallwit's study, which is the longer-term trial that looked over 2 years of linagliptin compared to glimepiride. And although there was a slight advantage to begin with in terms of the A1C lowering with the sulfonylurea, by 2 years the agents were very similar in terms of their A1C lowering. Just to go back to that study, the reason that the Carolina study was designed and is quite exciting is because in this study, although it wasn't particularly powered to show it, there was some suggestion that there were lower events of cardiovascular composite endpoint, particularly stroke outcomes with the DPP-4 inhibitor. I think the other factor is adherence to therapy, and DPP-4s are well accepted by patients, and we know that if you have a once daily regime compared to a twice or 3 times daily regime, patients are more likely to comply to their therapy. And also we know that if you look at the different glucose lowering agents, that DPP-4 inhibitors do pretty well in terms of persistence. That's a percentage of people who continue on therapy, and linagliptin does particularly well because it's a fairly simple DPP-4 to use. So where are we with the outcome trials with DPP-4 inhibitors? As I've said to you, we've seen the data with the 3 trials, TCOS, SAVOR, TIMI, and EXAMINE, all of which showed cardiovascular safety. Saxagliptin showed an increase in heart failure hospitalization, but that wasn't seen with TCOS, so I think that's very reassuring. We have the Carolina study, which is the only outcome study really, which is a head-to-head with an active comparator, and the active comparator is glimepiride, and I think that's a very relevant and important study. And then we have Carmelina, which has already had its press release and will be presented over the next couple of weeks. We can see the data in full. So this slide here summarizes the characteristics of patients in the outcome studies with the DPP-4 inhibitors. And you can see that Carolina has some of the longer term follow-up, so it's 6 to 7 years, and it is the only one with an active comparison rather than being added on top of routine care. If you look at the baseline characteristics, they're reasonably similar in terms of most of the patients were in their mid-60s. There was a higher proportion of people with prior MI in EXAMINE, and also a higher proportion of people with prior heart failure in the EXAMINE study. And the A1C at baseline was pretty similar. And these patients were well treated with statin, so the majority were on other cardiovascular protective agents. So I've talked about Carolina, so this is the 6,000 patient trial, which will compare linagliptin to glimepiride. And I think that's the million-dollar question, because many of the other studies are added to routine care. And sulfonylureas are still very commonly used across the world. They're very cheap, they're very relatively easy to use, and they have good glucose lowering efficacy. The two downsides are the weight gain and the hypoglycemia. But I think if it's shown that a DPP-4 confers a cardiovascular outcome benefit over an SU, that will change some of the international guidelines. And the Carolina study has published its baseline characteristics, and we await the results with interest. So Carmelina is the study that you'll see presented at the EASD. These patients, this was a conventional cardiovascular outcome study, but the patients were enriched with renal disease, and so it will be interesting to see also the impact there in terms of renal impact on renal outcomes. So the Carmelina results, the press release was released on July the 19th. It met its primary endpoint, so it had similar cardiovascular safety to placebo. There was no new safety signal, but we really need to wait to about 3 weeks' time, well, 4 weeks' time in Berlin to see the full results. So that concludes my discussion of the DPP4s. I now want to move to the SGLT2 inhibitors, where we have two large published outcome trials, EMPA-REG and the CANVAS program, which in itself is 2 studies. Just to remind you that the CANVAS program is constituted of 2 trials, CANVAS and CANVAS-R, that there was a pooled analysis, and this was pre-specified that they would pool both the primary endpoint, which was a 3-point MACE, and also secondary outcomes. So on this slide, you see both of the studies next to each other. So you can see the EMPA-REG outcome study, the 14% reduction in the primary outcome, and you can see that the CANVAS program, CANVAS and CANVAS-R, also showed a 14% reduction in the primary endpoint, which was a 3-point MACE of cardiovascular death, non-fatal MI, or non-fatal stroke. This slide summarizes the composite of those primary outcomes. So if you can see at the 3-point MACE, exactly the same with CANVAS and with EMPA-REG. If you look at cardiovascular death, you can see a 38% significant reduction with empagliflozin and a 13% non-significant reduction with canagliflozin. If you look at non-fatal MI, similar 13 to 15% reduction with both empagliflozin and canagliflozin. And if you look at non-fatal stroke, you see the non-significant but increase of hazard ratio of 124 with EMPA, and the non-significant slightly reduced non-fatal stroke with canagliflozin. So the primary endpoint very similar, but some differences in the composite of the primary endpoint, particularly in relation to cardiovascular death. So if we look at the class, the SGLT2 inhibitors here, we can see that we now have cardiovascular safety, but also superiority. So here we're seeing the class, the SGLT2 inhibitors, showing consistency in terms of the impact on the primary endpoint, and we have obviously data to come with both dapagliflozin with the DECLARE study, which is a large study, and also VERTIS CV, which is the ertagliflozin trial. Now, what about impact on other important outcomes? And I think with the SGLT2 inhibitor, the 2 very relevant factors are the impact on nephropathy, and we saw this 39% reduction in incident or worsening nephropathy. This is from the EMPA-REG program, but you see similar findings with canagliflozin. And if we look at this composite primary endpoint, which was either double of serum creatinine, initiation of renal replacement, or death caused by renal disease, you see almost a halving of that with the SGLT2. So I think this has caused great excitement, and you'll be aware also of the press release regarding the CREDENCE study, which was published very recently and looks positive in terms of renal outcomes. So that's the SGLT2s, and I think there is a consistency with the studies published so far with empagliflozin and canagliflozin. There, I didn't show you the heart failure data, but there's also, I think, very positive data in terms of heart failure with the SGLT2s. Now, when we come to the GLP-1s, the GLP-1 receptor analogues are a much more heterogeneous class of drugs. So we have already published 5 studies, ELIXIR with lixisenatide in patients with acute coronary syndrome, liraglutide in the LEADER trial, semaglutide, the weekly GLP-1 used in SUSTAIN, And then we have Freedom, where there's a press release from the Intarsica, which is the implantable GLP-1, and then obviously XL, which is the weekly exenatide. Now, if we look at the structures of these GLP-1 receptor analogs, you can see why there's some differences when you look at the study, the molecules in terms of efficacy, in terms of A1C lowering. You see quite differences. So if you look at native GLP-1, we have what we call the exendin-based molecules, so lixisenatide and exenatide, which would include either the short-acting Byetta or the long-acting Bydureon, but also the implantable Intarsica are all based on an exendin-based molecule, which has not so much homology to native GLP-1 as either the liraglutide or either then we have the other agents which are then have a protracted action by being added either to albumin, which is albiglutide, or dulaglutide, which is attached to a modified IgG4 domain. We also have semaglutide, which is has 94% homology to GLP-1, is a weekly GLP-1 and has been modified both to protect against DPP4 degradation and to provide stronger binding to albumin. So this is a protracted, longer-acting weekly GLP-1. So we have a number of weekly agents now. Now, if we look at the outcome studies for the exendin-based GLP-1s, we have Elixir, which showed safety but no cardiovascular protection. We have the press release from Freedom, which it's not been published, but it met its primary and secondary endpoint, which was non-inferiority for cardiovascular safety. And then we have XL, which was published and which essentially showed a non-significant reduction in the primary composite cardiovascular endpoint. So it was a 9% reduction. So for non-inferiority for safety, it was significant, but it didn't reach superiority. And if you look at the breakdown of the composite endpoint, you can see that there was a non-significant reduction in cardiovascular death, a 5% reduction in non-fatal MI, and a 14% but non-significant reduction in non-fatal stroke. So we have three essentially neutral trials. If we move to the other two studies, so this is LEADER with liraglutide, which is the daily GLP-1, where there was a 13% reduction in cardiovascular outcome, which was significant. And in SUSTAIN, which is an interesting paper because it was published in the New England Journal of Medicine, it was not a pre-specified analysis that they would look for superiority. But the journal did that and essentially showed superiority and a 26% reduction in the 3-point MACE outcome. So if we look in contrast to the other two classes, so the DPP4 and the SGLT2, where the data published so far shows consistency within the class, with the GLP-1s, we have some differences. So all of the GLP-1 studies show safety in terms of cardiovascular disease. So they show safety, but if we look at in terms of superiority, we have 2 studies that show superiority and 3 studies that don't. And there are many reasons we can discuss why that should be the case. And we'll have some further studies that we'll publish that may help us. So with the oral semaglutide Pioneer 6 and the larger dulaglutide study Rewind, which we'll publish later. Now, if you look at XL, it may be the fact that it's an exendin-based GLP-1, or it may be to do with the study conduct, so that we know that many of the patients continued their medication early, so nearly half of the patients prematurely discontinued study medication. The study was relatively short, So that may be a factor in the results. So if we summarize the cardiovascular outcomes with positive outcomes, we have 2 with the SGLT2s, we have 2 with the GLP-1s. We see some similarity in terms of the primary endpoint, but if we look at the secondary endpoints, we see some reductions in cardiovascular death in both in EMPA-REG and LEADER. We don't tend to see that in the Canvas study, and we didn't see it with SUSTAIN. With the SUSTAIN study with semaglutide, we see quite a marked reduction in stroke rate, a 39% reduction in stroke, whereas with the SGLT2s, we didn't really see much impact on stroke, and if anything, in EMPA-REG, a slight increase, a non-significant increase in non-fatal stroke. So if we look at the impact, so there may be many factors that may explain differences that we see in the outcome. So one may be the impact on other factors. So for example, if we looked at impact on A1C, in some of the studies there's a deliberate design attempt to try and minimize differences in A1C. So certainly that was the case in LEADER and EMPA-REG, and to a certain extent Canvas, to try and not drive differences in A1C, but despite that there were modest differences in A1C between the 2 arms, although it's felt that that wasn't big enough to really drive the benefit that was seen. With semaglutide, I think that's more difficult to argue because the difference is it's quite a powerful glucose lowering agent, and it was there were really quite significant differences in A1C between semaglutide and routine care. If we look at weight, again, you're trying to minimize differences between the arms, but there was modest weight reduction with EMPA-REG, Canvas, and LEADER compared to the routine arm, and again, much more difference with semaglutide, nearly over 4 kilogram difference in weight. And so some of these differences in glycemic control and weight may drive some of the differences. And there was also quite reasonable differences in blood pressure, particularly in Canvas, but also in SUSTAIN. So if we look at other factors and other confounders that may drive some of the differences, what happens in the routine arm, particularly in terms of the use of insulin and the rates of hypoglycemia, can of course influence outcomes. So it may not just be the benefits in the intervention, it may be the harm or the increase in adverse events in the standard arm. And you can see that, that there wasn't huge differences between the incidence of hypoglycemia, but in LEADER, in SUSTAIN or EMPA-REG, but there were differences in LEADER. If you look in the placebo arms, there tended to be in most of the studies slightly higher rates of patients on insulin. So all of these factors need to be taken into account when we're thinking of how to explain the outcomes. Also, if we look at the outcomes in terms of the SGLT2 studies, particularly EMPA-REG, there was a suggestion of an earlier benefit with the SGLT2s compared with the GLP-1s. There was some heterogeneity in the magnitude for the individual components, which I've already talked about. So if you look at cardiovascular death, it wasn't really a factor in SUSTAIN 6. There was a non-significant reduction, whereas in EMPA-REG that was much greater. Heart failure outcomes much better for the SGLT2s, if we look at the microvascular outcomes, there was the higher rate of retinopathy with semaglutide, which is being investigated, but may be also driven by the fact that of much greater and more rapid reductions in HbA1c. Insulin was introduced in most patients in many of the placebo arms for all of the study, and we've talked about the differences in hypo rates and A1C. So are these, what are these benefits due to? And they could be differences in trial effects. So, and as we've said, there are some differences in trial design, both within the class of drug studied, but between the class of drugs studied. There are also impact on other cardiovascular risk factors. Some of this has been looked at in terms of many people have said that the A1C differences are really not enough to drive some of the differences, and you'll be aware that there's a mediation analysis which has been published looking at EMPA-REG, looking at tries to see what explains the difference in outcomes. And also, obviously, there may be key mechanism of action changes, particularly with SGLT2s or GLP-1, that drive these factors. And I think many of the questions are these findings representative of all groups? So they may well apply to the 17% of the diabetes population that have established cardiovascular disease, but do we know whether these findings could be extrapolated to people at lower cardiovascular risk? We don't know the answer to that question yet. So just to talk about some of the mechanism of action issues, I think it's well known the effect of GLP-1 in the cardiovascular system, both in terms of the kidney, in terms of both through the vascular system itself, and in terms of direct impact in the heart and myocardium. And this is well articulated in a number of publications. In terms of the SGLT2 inhibitors, again, there's been many discussions regarding the impact of SGLT2 class on cardiovascular outcome, either through glucagon, either through reducing the preload through the kidney and through the vascular system, but also impacts itself on weight loss and adipose tissue, and also through ketone bodies as well. And so there are many discussions regarding this, and the mediation analysis done with EMPA-REG seemed to suggest that it was offloading that may have a particular benefit. So just to really then talk about other factors, I think it's really important to remember that these patients were well treated for cardiovascular protection. The majority are on antihypertensive, lipid lowering, platelet inhibitors. And so these studies demonstrate a benefit of these agents over and above good multifactorial care of patients with type 2 diabetes. The treatment guidelines are starting to reflect these cardiovascular outcome results. So the standard of care, the German guidelines, the Norwegian guidelines, the Canadian guidelines are all starting to make amendments. So they start to, particularly in the US and in Canada, they already talk about empagliflozin and liraglutide in people with established cardiovascular disease. And you'll see that the new guidelines come out also, I think, are more proactive in the use of these therapies now. Now, what about the future? And just very briefly to talk about what's in the pipeline. We've talked about with DPP-4 inhibitors. So Omnion, which was the weekly DPP-4 inhibitor, that's already been pulled, not because of a safety concern, really, I think more around a commercial decision. Carmelina will hear very soon, and Carolina you'll hear soon. We've talked about Pioneer 6, which is the smaller study with oral semaglutide, and then I think next year we'll see dulaglutide, which is with the Rewind study. The oral semaglutide data I think is quite interesting because one of the barriers to GLP-1 is the injection, and there is now quite a comprehensive phase 3 program looking at oral semaglutide, and we published the phase 3 data in JAMA and showed really quite significant reductions in A1C of nearly 2% with the oral semaglutide, really quite remarkable weight loss. So this is significant weight loss which is equivalent, and in the orange is the injectable semaglutide, and you can see that the oral doses, particularly at the higher doses, are close to what you see with the weekly injection, and with kilogram weight losses of between 5 and nearly 7 kilograms. And then we have the data with the SGLT2. So Credence has already got a press release about the data, which is looking at a renal endpoint. And I think here we're starting to see studies specifically in heart failure. So we have the DAPA heart failure study, the DAPA chronic kidney disease study, and EMPEROR, which is looking at empagliflozin. So increasingly, we're seeing studies not in just patients with type 2 diabetes and cardiovascular disease, but looking in patients with heart failure and chronic kidney disease. So in summary, the data in type 2 diabetes shows that improved glycemic control does have a modest effect on improving cardiovascular outcomes, and traditional glucose lowering therapy shows cardiovascular safety but not a positive impact on cardiovascular outcomes. But the newer glucose lowering therapies, in particular the SGLT2 inhibitors and the GLP-1 receptor analogs, are starting to show cardiovascular protection within the class of SGLT2 that appears to be fairly consistent. However, with the GLP-1s, there appears to be some differences in the outcome. It would be great to see combination therapy with SGLT2 and GLP-1 and their impact on cardiovascular outcomes, but those studies are yet to be really implemented and published. And further outcome studies will likely expand our understanding and change the guidelines moving forward. So thank you very much for your attention. So I'm happy to take any questions if there are any. Hello. Okay, so I can see some of the questions coming through regarding the dosage of semaglutide. With the oral dose, they're exploring doses from 3 milligrams, 7 milligrams, and 14 milligrams. So the dose ranging that was studied in the phase 3 went up to 40 milligrams, but in the phase 3 program, sorry, I showed you the phase 2 data. The phase 3 program, it's 3, 7, and 14. With the injectable therapy, the weekly, it's 1 milligram of semaglutide once a week. In terms of, there's a question around which GLP-1 analog is better. I think that depends on your perspective. I think there's cost differences, and for some patients, the cost is an issue. For some patients, the weekly injection is preferred, and dulaglutide and semaglutide are very easy to administer. Exenatide once weekly a little bit more difficult because of the device, but liraglutide is still very commonly used, and it's a weekly GLP-1 because it's very easy to administer. In terms of, I suppose, the outcome data, liraglutide has the best, most convincing data in terms of cardiovascular outcome with LEADER, I think, and the impact on cardiovascular death. In terms of the SGLT2 data, I think the data is a little bit more consistent across the class. So I think empagliflozin and canagliflozin both have good data. Empagliflozin did show that impact on cardiovascular death, and as you know, there's just some signal that came through Canvas, which I didn't go into, but is there in terms of both fracture and amputation, which didn't appear to be the case with the empagliflozin program, but that may be due to differences in collecting data. So I think the EMPA data is very reassuring, but canagliflozin is still commonly used. DAPA has got good a good clinical trial program, but we haven't seen the outcome data yet. There's a question about pregnancy. So at the moment, the agents that we have safety for in pregnancy are really the old agents. So metformin and insulin, probably the best data. We won't, I don't think, ever get pregnancy studies with SGLT2 inhibitors, DPP4s, and GLP1s. What we're likely to do is, as these drugs are used more commonly, is to get more case reports because we've got increasingly young women with type 2 diabetes who may well fall pregnant while on these agents, although that's not optimal. So I think it's likely that the data for their safety will come through really more case reports and surveillance rather than actual trials. I think there's a question about the increase in amputation. I think it is a little bit of a worry. It's a definite signal. It doesn't appear to be, if you speak to the investigators involved, when you look at Canvas and Canvas R, it appears to be fairly consistently seen. It's about a twofold increase across whether it's major or minor amputation. These are fairly frail comorbid patients, and the absolute increase is relatively small, but it's not, I think, to be ignored. And we just really need to be interesting to see whether there's a signal with dapagliflozin. And I think there's lots of real world studies looking at this as well. But I think it's still a hot topic, and we should still perhaps be a little bit concerned until we've seen more data. Metformin in type 1 diabetes. I think the removal study really showed only a very modest impact of metformin in type 1. It showed about a 0.3 reduction in A1C and a very modest weight reduction, and really no impact on the surrogate outcome for cardiovascular disease. I think that the data with the SGLT2 and the dual SGLT1 and SGLT2 inhibitors, so the data coming out with dapagliflozin and sotagliflozin, actually is a little bit more encouraging, although we have to be concerned about ketoacidosis. So I think in future for type 1, the therapies that are likely to make a bit of an impact are the SGLT2 and the dual 1 and 2 inhibitors rather than metformin. Carmelina, somebody asked about I know it's being presented at the EASD at the end of September, beginning of October, and I would be predicting that there will be a simultaneous publication in one of the large journals. The stroke risk is not significant with empagliflozin. It was a hazard ratio of 1.24. It wasn't statistically significant, but I think it's something that we just have to keep a bit of an eye on. Cost effectiveness. So that's a great question, and I think there's no doubt that if you look at the GLP-1s, they are relatively expensive. So there's a question about cost. Is the cost acquisition, what it costs people to provide the drug for a month, and there's cost effectiveness, which is if you look over 10 years and you look at mortality and cardiovascular outcomes. So increasingly, I think with the outcome studies, the cost effectiveness is starting to look more encouraging, but the acquisition costs, these therapies are still more expensive, and we really need to try and push for the price to be more accessible to a wider number of patients. There was a question about, is insulin therapy going to abolish? I think the guidelines will start to push GLP-1s more as an injectable therapy for type 2 diabetes, but I think insulin is still a hugely important part of insulin management. It's obviously the complete mainstay for type 1 diabetes, and it's still important for many of our patients with type 2 diabetes, particularly I think basal insulin and basal insulin in combination with GLP-1s or SGLT2s or DPP4s. I'm just trying to look down. You've got lots of great questions. I'm not sure if there are any more. Okay, so the SGLT2 in left ventricular patients. So I think the data in heart failure with both HFpEF and with preserved or reduced ejection fraction is being, there's studies, the Emperor study, there's DAPA studies looking in both cohorts. I think the data with SGLT2s in heart failure in both groups is looking actually quite positive. It was obviously a secondary outcome in the trials, but I think increasingly if patients have comorbid heart failure, we are choosing SGLT2 inhibitors as a treatment option, and I think that's probably reasonable. I think whenever you use an SGLT2, you have to be careful of other comorbidities of chronic kidney disease, if patients are fasting, if they're otherwise ill. We need to be educated and make sure that our primary care doctors are educated about SGLT2 inhibitors and using them in frail elderly patients with other comorbidities. So somebody's asked about an SGLT2 with a GLP-1. So in terms of weight loss, the combination isn't quite as good as bariatric effects. So if you look at bariatric surgery, you're wanting weight loss of double figures. So you're wanting to get weight loss of 15 to 20%. So we can get, and we know with bariatric surgery that we can often get weight loss much higher than that. If we look at the low-calorie diets, there are numbers of studies now with the meal replacement diets where you're getting close to 15%. I think if you look at semaglutide, they are doing studies now at an obesity dose, which is a higher dose than the approved dose for diabetes, and they're starting to get the press release with double digits, so 12-13% weight loss with a higher dose of semaglutide. If you look at the duration study of dapagliflozin with exenatide, the weight loss was an additional weight loss, but it was nowhere near where we'd get with bariatric surgery. I think if you look at drugs for weight loss, it's the combination of the dual agonists, so GLP-1 receptor analogs with glucagon agonists. So I think there are clever, smart combinations of co-agonists, but I don't think SGLT2 and GLP-1 will quite get us to bariatric weight loss. But I think as a combination is interesting to look at in terms of cardiovascular outcomes. So choice of DPP4s in patients without end-stage renal disease, I think there's little to choose between them. I think all of them have got reasonably good clinical trial programs, and it really depends on your availability across the world and relative costs. Somebody's asked about teninagliptin. I can't really comment on that because it's not really an agent that's available in Europe or the US, so I've had no clinical experience of teninagliptin. I can't even pronounce it, so that's not so good. I think, so there's a really good question about diabetes in the young, and I think that's a great question because I think those young people, I think if we're talking about young adults, so people over the age of 18, I think increasingly, although the clinical trials don't include so many young people, I think that we want agents that are easy for patients to take, but also may be associated with weight loss and a very low rate of hypoglycemia. So I think that increasingly the SGLT2s and the GLP-1s will have a role in younger patients. In children, the trials are ongoing, and most of the agents at the moment don't have a license down to very young children. I think that's pretty much many of the questions that you have asked. I can't, hold on, let me scroll down. Yeah, I think those are most of the questions. Oh, here we go. Which is the most appropriate in diabetes in older patients? I think there was a question in older patients. I think in very old patients where they have comorbidities, I think the DPP4s are an excellent choice. They're very low rates of hypoglycemia. Often they're renal, particularly drugs such as linagliptin and even the others with dose adjustment can be safe in patients with comorbid chronic kidney disease. Somebody's asked about the risk of euglycemic ketoacidosis. So I think that used to be a reasonably high risk when we didn't know so much about the SGLT2s. I think the cases have now come down because I think we're much better at, I think the cases that we saw were when we were using it in type 1 patients, in people that we thought had type 2 but in fact had type 1 diabetes. I think when you try and aggressively reduce the dose of insulin, I don't think that's a good thing to do with SGLT2 inhibitors. You shouldn't really aggressively reduce the dose of insulin. And I think the other danger is in people on a very low carbohydrate diet. So I think we're much better at educating patients now, and we've learned from the clinical trials. We don't. I think it is a risk, but we don't see it quite so so commonly now. Yeah, end-stage renal disease. So I think, as I said, linagliptin I think is great because it's got use really right across with no dose titration right across in patients on dialysis. I think there's other options with the insulin is obviously a good use. I think the DPP, the SGLT2 inhibitors. So we have this dilemma where the license, and it varies in different parts of the world, but certainly in Europe, you need an EGFR above 45, and yet we have studies coming out with Credence and other studies with EMPA-REG and Canvas where we recruited people down to an EGFR of 30 where we showed benefit. So I think SGLT2s are likely to be a really good option for people with chronic kidney disease in the future, but we need to marry the license with the benefits that we see in the clinical trials. There's a question about microvascular complications. I think that's a great question, and at the moment we don't have big enough and long enough studies to really look at the impact on microvascular complications. And the metformin question in type 1, as I said, I'm slightly underwhelmed by the evidence of metformin from the removal trial. So we don't tend to routinely add that to our type 1 patients, certainly our routine type 1 patients. So it's not something I would necessarily do routinely. Oh, the ketogenic diet in people with diabetes, I think you have to be very cautious. The very low carb diets, I think particularly if people are on SGLT2s, are really not a good idea, and that's where we've seen some of the cases of euglycemic ketoacidosis. So I think, yeah, I think that was most of your questions actually. Okay, so I think thank you for your great question. There was lots of them, so that's fantastic. Thank you for your attention this evening. Or it's the evening here. I'm not sure what time it is over with you, but thank you very much. To say goodbye now. Thank you.